Prifysgol by Abertawe. Croeso cynnes iawn i'r cyfarfod arbennig bore yma. So good morning everyone, I'm John Williams, I'm chair of the board of Swansea Bay University Health Board, and a very warm welcome to today's meeting. So we're saying croeso mawr, a particular welcome to people around the table for the first time today. Charlotte Rees is with us in person, our new independent member from the university. So Charlotte. We have Alan on screen, Alan Llewellyn, Associate Board Member, Local Government, and then Helen Annandale is with us as the Chair of the Health Professions Forum and another Associate Board Member. And we do have Pat with us, as always, Pat Dunmore from Stakeholder Reference Group. So I think we're nearly there now with our Associate Board Members. We have a full complement. So, croeso mawr i chi gyd, a very warm welcome to you all. So we've had apologies from Nuria Zole, who's an independent member, Richard Evans, our medical director, and Raj Krishnan is here representing. Raj, warm welcome. Raj, we've got apologies from Chris Morell, and then Alison Clark is here representing Chris, and then Roger Edwards is here, consultant from Alison. Roger's been here before, of course, talking about the matter on the board agenda today. So, Roger, we are really grateful that you've given us your time this morning. Thank you. So, as I said at the start, this is a special board meeting today. The board is the governing body of Swansea Bay University Health Board, and as such, it is the highest decision maker, highest level of decision making in the organisation. We are the stewards for £1.8 billion of public money. We employ over 14,000 home-time equivalent staff, and we are responsible for the healthcare and trying to improve and reduce health inequalities for 400,000 people in Swansea and Meath Talbot, and then much larger populations for our regional specialist and tertiary centres. So all that makes us one of the largest public bodies in the UK. So the board has weighty responsibilities in terms of doing its optimum for the people of Swansea, Meath Talbot, and more broadly for specialist services. The board conducts its business normally in bi-monthly meetings when we cover the whole of our agenda. And the next meeting will be at the end of March, when we will be doing so. There are times, however, when we have to take meetings outside of our regular cycle because there are specific matters come up that we must address here and now. And we are at such a time today, and we are looking at service considerations around Porthine and Hospital Course, and we will be considering the temporary transfer we made in October of last year and whether the board is minded to actually extend that transfer. And we took the decision very much based on patient safety, and that is the domain that continues to be the particular focus for the board meeting today. But before we move into the agenda item, does anyone have a specific declaration of interest in respect of this agenda item that you haven't already recorded on our register? No? So thank you all very much. So Liz, with that, am I handing over to you?
Yes, thank you, Chair. And Rodney's joined us as well. We both came to present the original paper to the board, so we're going to do that with Raj's help as well. So as you know, 25th of September last year, we agreed as board for a transfer of Cynham West Ward to Singleton Ward 3. And that transfer was initiated in October. And we agreed to have that temporary transfer until the 31st of March. We're going to present you today what we've done since that transfer and whether the issues and concerns that we have been resolved. But essentially, we'll go through that. But what we're asking for us to consider today is a further extension of the temporary closure, and we'll just explain to you why we think that is the right thing to do. So the themes and the concerns raised were around patient and staff safety, and we'd had concerns raised by staff themselves around medical and nursing cover in hours and a lack of medical cover out of hours. And we also had some concerns around the acuity of some patients on the ward and the ability to care for those in a timely and appropriate way. And there were also some out-of-hours security risks associated with the isolation of West Ward Gwasanaeth. There were concerns around workforce, and that included an increase in temporary workforce. At times, we were using 50% temporary workforce on some shifts, and we had tried to address that with more support and some training and development, but actually it was a continuous worry for us that we couldn't staff West Ward appropriately. The culture that we were met with in Gwasanaeth, there were some difficulties with the multidisciplinary team working, and we'd had some issues raised by staff themselves, and we're continuing to look at those issues and work through them. I've already mentioned the security issues, but there was also some estates issues that were raised at the time. We moved the ward, and since then we've had some additional emerging concerns, which we've updated Quality and Safety Committee on and Workforce and OD Committee. And those concerns have been around patient experience, patient safety and the quality of care raised by patients and their families once we had moved, as well as the senior team who are now providing huge support to Ward 3 in Singleton. And they included incidents that had not been reported appropriately, incidents of harm to patients. All those concerns are being addressed, and we'll tell you how that is happening at the moment. We've provided senior nursing support embedded within the ward, additional training and development, and we've got a dedicated wraparound support provided by the tissue viability team particularly, and practice development nurses. And we've increased the monitoring and reporting mechanisms implemented. With regard to the workforce, we recognised that the staffing template on West Ward was not sufficient to meet the needs of the patients that we've now transferred into Ward 3, and we've developed a staffing rota to manage that. We are still using some temporary staff, but it's not at the scale that we were previously. And as I say, with the 7-day-a-week senior nursing support, plus the wraparound support of the site team in Singleton, the staff are feeling, when we've visited, and a number of us have, that they are in a better place and they feel well supported. Unavailability at the moment, we have 2.6 vacancies on the ward, but we're just about to fill those, one with a student streamliner and one with somebody that we've trained internally and will be coming out of university this year, and that will improve our reliance on variable pay hugely. The variable pay cost has reduced by about 200,000 since we have moved, and will continue to reduce as we fulfil the substantive establishment. What we'd like to consider is that we extend the service transfer for another 6 months to the end of September, and I'll go through the reasons why we think that should be the case. I'm sure Rhodri will come in, but at Gwasanaeth, there was a reduced medical cover. We didn't have 24/7 medical cover for Gwasanaeth, and sometimes that meant that we were transferring patients back into the acute sites out of hours on weekends, etc., for care. Since we've moved to Singleton, Rhodri, do you want to say there is now?
We've got a registrar that's covering it 24 hours. We've got much better consultant cover actually. Nikki Leopold and Dr. Maddock are taking it into us after half the board each. We've got 2 junior clinical fellows that are there constantly in terms of medical staff every day between 9 and 5 supporting the ward. And I think it was quite difficult to persuade people to work in isolation and whereas actually they're very happy to rotate to Ward 3 because they feel more of a team there, and they've got other people that they can go to in terms of the site team, but there are other doctors there as well. There's not that sense of isolation that there was when I think people were working in Gwasanaeth. And I think it's had a big impact on registrar active hours. So things that can be simply treated there, including giving intravenous antibiotics, that can be done out of hours now. with the supervision of the medical registrar, without that person needing to be transferred back to Morriston. And I think, in terms of the patient experience for frail, vulnerable people who are recovering from acute illness, that's a much better model for them.
And are we recording the numbers, Rodri? Are we recording, sort of transfers to Morriston avoided? Are we recording all?
I haven't got the data with me.
But we are though.
Yeah.
That's important in terms
Yeah.
of, sort of better service for patients, really.
Yeah, so we can compare the previous and the now, really.
Thank you.
The temporary staffing issues, as I say, are partially resolved, but we've got plans to further resolve that. There was also an issue with sickness levels. Sickness levels are still high on this ward, but they are reducing, and we're working closely with the teams to support that. The lack of security out of hours is essentially resolved, being in Singleton, for all the reasons that we've just said. The increased patient acuity and the pressure to surge has also been partially resolved because we have restricted that area to 30 beds and the next patient spaces. The reduced management and leadership support that was felt by the staff in Gosainen has also been resolved because we've mentioned that senior team that is wrapped around on a 7-day basis, really. The increased incident reporting, we believe, is because there was under-reporting at Gosainen, and we saw an increase in incidents like pressure ulcers being reported once we had that oversight and overview of every patient on that ward. That has now started to reduce, and that is because of the extra support and development we've given those staff. And they've accepted that, and they are improving the care that they're providing to our patients through that. And they recognise that and are welcoming it. The timeframes of the associated service return to Westward, we would have to look at the medical cover if we did that. And we would have to look at the estates issues that since we've vacated the area, we can see we've had that surveyed, and we'd have to do some work from an estates perspective. And for all of those reasons, that's why we're coming to ask for this extension of the temporary closure until the end of September. There are some financial implications associated with this, and variable pay is one of them, but we feel we can continue to reduce that. We have put extended nurse leadership in there. We don't want to withdraw that yet until we're very confident that's had the impact that we wanted. And of course, as our staff have travelled from their base in Gosainen to Singleton, we always pay their travel expenses. So that, I think, is all we wanted to say, Rodri, unless there's anything you want to add.
No, I think overall it's been a success for the staff and for the patients that are being involved, and I think it allows us to embed a more consistent rehabilitation model. I think because some of the senior leadership that's been provided in Singleton is also covering the rehabilitation wards in Neath Talbot, and I think there's much more work to do there in terms of having a consistent model. But I think it helps with that as well.
And within this extension, we would continue to work with the teams and staff, and we would continue to look at solutions, and we would also start to look at this in the context of our clinical service plan, and we would want to engage with the community and the public as well.
Thank you. I'm going to ask Raj if he wants to add anything, Jean and Rena as the chairs of the committee. But before I do, can I just ask on 3.3, in terms of any recruitment for a 24/7 service in Westward, can this be managed then from within the existing resource envelope, given a significant financial deficit facing the health board?
So the recruitment would be associated with the return to Gosainen.
So can it be, what I'm asking is,
How do
you have only the current envelope you have, no growth monies. So can this be funded from the current resource envelope?
No.
Raj, would you like to come in, please?
No, thank you, Chair. And I think the fact is the biggest concern when this model was proposed was with regards to the reduced medical cover. And I think the fact is the board needs to be aware that the fact that the 24/7 medical cover that is actually available from the consultant medical team that's actually been arranged is actually acceptable, and it's not just acceptable to the fact that it's actually the consultant board is actually sorted. So I think it's very important to know that the clinicians are actually happy with the existing model, that we are actually not putting any patients at risk. And I think that needs to be highlighted.
That's because it's on site at Singleton.
Yeah.
When you get the cover. Where the cover is there, as Rodri has highlighted.
Yeah, do you want to come in?
Yeah, I just want to come back to the point you raised, Jan. I think it's really important in terms of what we've learned and the improvement we've achieved. And that when we come back to make the final decision, we will need to take into consideration what the point that you've highlighted, Jan. We're about to spend board development looking at our financial position, which is extraordinarily challenging. And anything that adds additional costing that we have got no line of sight to funding for is just something we're not going to be able to manage. That will need to be part of the considerations when we come back. Yes, what's right for patients and clinically, how do we keep our staff safe and covered and supported appropriately, but it will need to be in that context as well. It's really important that the board understand that.
Thank you, Abby. Jean, from a quality and safety committee perspective, we've been looking at the safety and quality issues associated with the transfer. Anything you want to bring to the board's attention?
The board should take assurance from the fact that we have uncovered quite a number of issues in terms of potential harm to patients and obviously our staff with the security issues. But what has transpired since the move, and the move was very well managed because there were inherent cultural problems that had to be dealt with. I'm not sure that they are fully dealt with at the moment. And I would be interested in understanding what the profile of that absence looks like. Is it long term? Is it short term? So there's still more work to do, but I think the board can take assurance from the fact that we are now providing better medical care to our patients with less potential for harm. We are measuring any harm that we are identifying, and the staff are being appropriately trained as well.
Andrina, that takes us into Quadcom, given the staffing issues. And do you want to give us an update on what Quadcom's been
Yeah,
doing?
and we have been getting regular updates on this situation. And as Jean said, in some ways, we've done a lot of work with the staffing and in particular the leadership and training. But there is still, I think, a way to go in terms of the culture issue. And the particular thing that's referenced in the report that I was going to refer to was the cost pressure of the additional leadership and the redeployment of the staff. In terms of leadership, clearly at this moment in time, we need that. But as we move on, hopefully with an improved culture and with improved training and development, we may not need as much leadership input. So there is that potential saving. And in terms of the redeployment of staff, clearly there were staff that didn't transfer because they couldn't get to Singleton. I think it was in terms of transport. Obviously, I think they've been redeployed to the community, is my understanding. But we do know there are vacancies in the community. And in a sense, hopefully we can redeploy people successfully into permanent posts within the community. And then that cost will be assisted in terms of reducing the cost at the moment. So there is, if you like, some way to go, but I think over the next 6 months, we can probably refine these things. And obviously by that point, then we'll be in a better position to know what the true cost is of leaving the ward in Singleton if we were going to choose to do that.
That's really helpful. I'll open it up more widely for questions. Tina, did you want to come in?
I do want to come in and just, I think it'd be remiss of me not to remind the board of the issues that we've had around political sign, and particularly through members of staff and anonymous emails that we received. And as obviously members of staff are not happy with the temporary arrangements and the additional, there's the describing it scrutiny, but support that we put in place. So I do think that's an ongoing risk that we potentially, any decision made today would get a reaction and potentially would be out emailing again ourselves and other stakeholders. So something that we need to bear in mind.
Bettina, what engagement are we having with the partnership forum?
Yeah.
Then, please?
So we've discussed this wide partnership forum. They raised concerns that they didn't feel the emails represented their members. They felt they wasn't sure who was behind the emails, and raised concerns about information governance and cybersecurity, which we took advice around. They haven't received any escalations through their members. That was Unite, RCN, GMB. Unison chose not to attend those discussions and meetings, so we don't know their position on this. So there is a risk around Unison members, I would say.
We'll come back to any communication subject to the board's decision at the end. Tina and Richard, I'll come to you on that at the end, depending on what the board's decision is. Any further comments, please? I've got Anne-Louise, then Steve.
Thanks. Roger mentioned that at the moment that there seems to be satisfaction from staff and patients. I just wondered what actual feedback you've had from patients and their families, because obviously it's a different journey for them. And I wondered what that is, and is it being recorded?
So we do record some of the feedback from patients. I suppose a lot of my feedback comes from the doctors working there and conversations with Dr. Maddock and Dr. Leopold about how they perceive it. But I think they felt much more confident with the board based in Singleton than when it was in Gorsainen. And I think we can go back to friends and family feedback on which I think is generally positive.
But there hasn't been anything raised by the family of the patients with regard to.
Because of the location.
No.
Thanks.
So Steve and Richard.
A couple of points, if I may. On the paper, 2.5 is headed options for consideration by board members. 2.55, one is the recommendation you just outlined. I looked in vain for a 2.52, so it's a single option. So for the avoidance of doubt, somebody reading this paper would not understand why there wasn't another option. But the only alternative option would be to move everybody back to Gorsainen, and that's not recommended.
Not at
Yep,
this point in
okay.
time.
At this point. The second, and we've already touched upon the finances of it, fewer beds, but more doctors, all good. But we are being asked to approve, in effect, an investment, albeit for 6 months. And we don't know how much that investment is at this stage. So we're running a bit blind, and we've been told we shouldn't be approving investments that we don't have a good business case for.
So from the doctor perspective, it's being covered by what is already in Singleton. From a nursing perspective, we had a variable pay issue at Gorsainen. We've transferred the establishment that wanted the staff that wanted to transfer. We've been topping that up. There are now only 2 vacancies there, and we've got those filled, and they'll be started soon. So the variable pay will come down.
Yeah, and it would have been, and it would be still good to see those numbers set out, because it may be it's going to be cheaper, but we don't know.
Well, when the board does come back to this matter, then we will have the full costings on. Richard, did you want to come in there?
Yeah, just coming back to Anne-Louise, but this point around the travelling, I think it's important just to note that the patients at Singleton now and we're in Gorsainen, they aren't just Gorsainen residents, and they serve the wider area. So it's a really important point to make there around who the patients are. So it's a much wider area than just the Gorsainen area.
I think that is an important point, because it is a much wider service utility for residents of the area. Thank you. Any other comments, questions? Jean, jump in.
From a practical perspective, have we engaged estates in the potential refurb of the ward already?
We've started to look at what it would take to get the ward up to standard for us to be able to move back into. And I think when we come back, as Steve said, all of the options and the financial implications of that, as well as the time, etc., to engage to get the ward back to a state that's fit, will be included. Yeah, those explorations have already started. Thank you.
I think it's important to make that point, Jean, because as we discussed in relation to the cellular pathology solution that we're working with in Hywel Dda, we cannot take that in isolation, and we cannot take Gorsainen ward in isolation. We will have to look it up in the context of the total discretionary capital programme. And I think it's important that we understand that, none of these can be taken as standalone matters because they have to be taken within the overall resource envelope available to the Health Board. So that's a really important point. Thank you. Do we have any other? Richard, did you want to come back again?
Yeah, just around the communications around this.
The board needs to make a decision first, Richard, before we would consider what communications we might make. So are we content to move to the recommendations then? Any further points? So we are firstly asked to take assurance from the actions that have been taken since the transfer of the board in October last year, both in relation to staff, patient and family concerns. Can we take assurance from what we've heard and read this morning? Thank you. And then we also asked to take assurance from the information we've had that those concerns, they've been mitigated and resolved as far as they can be, as set out in the paper. So on that basis, are we prepared to approve an extension to the current temporary transfer for 6 months from the 1st of April, because the current one runs till the 31st of March until 30th of September? And we do know that there are listening events planned, and Richard, I'm sure we can come on to those in a moment. Well, are we content to approve? Thank you. So Richard, shall we come on then to communications and listening exercises, please?
Yeah, so a couple of things around that. Clearly, there's been concern in the community about Gossaina Hospital, so I think it's important that when we communicate this decision in terms of the extension of the temporary transfer, that we relay and remind everybody about the wide range of services that remain at Gossaina, because it is a vibrant building for us in terms of the services that are provided there with a wide range of teams. So we will absolutely be doing that. It's also important to put into the context of the clinical services plan, which the working title is Transforming for the Future, because that will look at the provision of services in the round then across Swansea Bay. So that's a process that will obviously involve wide-scale public engagement. Before that, however, we will undertake a listening event in Gossaina, so that the residents of Gossaina have an opportunity to feed into that process before we start putting pen to paper. On the immediate sort of decision and the communication around that, we'll issue a notice, so we'll put something on the website, we'll issue a statement, and we'll also engage with stakeholders in the community as well to make sure that they're aware of the decision that we've made here today. And as I said, reiterating the vibrancy of what remains of Gossaina as well.
Thank you very much, Richard. And Deb, I know you're bringing a paper to the board in March on community by design, and that will set out, all the potential for a site like Gossaina to have. Yeah.
There's a lot of focus on how we move things from acute hospitals back out to the community. I think Gossaina will play a pivotal role in that. It's a good estate in a good position for us.
Thank you, Deb, and we look forward to that in March. And, message out from the board, Richard, we have no intention whatsoever of closing Gossaina Hospital. Any suggestion that we have is completely false and baseless. So we need to make sure that that message goes out, please. Thank you. Tina.
I just also think it's important around the communication plan for staff as well with this decision, given my comment earlier on in the meeting, that we do feel that they feel engaged with the decision and hear the same messages for other stakeholders, and we prioritise that stuff.
Thank you very much. So can we have those twin tracks going at the same time then, please?
Yeah, but potentially we'll issue a midweek message and we'll actually do the external stuff at the same time as well. So.
We also do face-to-face with those staff as well. Yeah.
Thank you. Liz, do you want to answer
That's
that?
what I was going to say, Tina. Locally, I would suggest when we've made a decision today that we inform the teams that are currently there, and we'll do that in person. And the senior leadership team within Singleton will do that, and we will hold events for them to engage with us going forward.
Well, this was a single issue and we don't have any formal other business, but I think Abby wants to just update us on one very welcome appointment.
Indeed, thank you very much, Chair. I'm pleased to confirm that we have an interim finance director who will be starting with us on Monday. She will be known to some colleagues in the Health Board because she worked in the organisation a little while back as the finance director of Morriston Hospital in a previous previous organisation, Claire Osmaston-Little, who is joining us from Digital Health and Care Wales. We're very grateful that they are going to release so quickly, obviously because we need to get going in terms of securing Claire into the role. She's going to be here on Friday afternoon to start her orientation into the organisation. We will need to share her for a couple of weeks, or possibly a couple of months, so that she can land their end of year position as well, where they're just working through their own setting up arrangements internally. So I'm really pleased to confirm that, and Claire will be with us on Monday. So that's really good news. So I'm really pleased.
Thank you. We really look forward to welcoming Claire next week. So, dan ni'n mynd I gair y cyfarfod nawr. Diolch yn fawr I chi gyd am eich cyfraniadau. Gweld chi am y tro nesaf. So I'm going to close the meeting now. I think thank you all very much for your contributions and the next time, which will actually be the next regular meeting of the board on the 26th of March. Diolch yn fawr iawn I chi.